हाँ बोलना. So in case of adverse drug reactions like gout, these are, if insomnia is there, we can give drugs like hydroxyzine, diphenhydramine, trazodone, etc. And allergies we can do in that way. Then we can manage the ADRs, various ADRs accordingly. If there are seizures, then we can suspend the suspected agent till seizures are there. Initiate the anticonvulsant therapy, increase the pyridoxine to maximum daily dose. Pyridoxine helps in reducing the toxicities related to this INH and rifampicin. Restart at lower doses, discontinue and switch the different agent. Particularly many drugs, they causes peripheral neuropathy. In that we can use it. Increase the pyridoxine to 200 milligram per day, because this is and most of these are causing INH, rifampicin, etc. So we can increase the pyridoxine to 200 milligram per day. We can change the injectable, that is like capreomycin. We can initiate the therapy with tricyclic antidepressant to, we can lower the dose of the drug, and then otherwise we can discontinue the drug which is causing severe ADR and switch to different agent. So these are how we are managing the ADR. The biggest problem is hepatitis. Suspend all the therapy pending resolution of hepatitis. That can be done, or there are other ways also, because hepatitis or these hepatic toxicities are always found dose dependent. So earlier what was there, that the doses which were given, as I told you, they were weekly doses. Weekly means 3 times a week, like that, or 4 times a week. That means they were not per day doses. So if they were not per day doses, then comparatively their doses were high. If it is thrice a week, then it almost it was compensating 2 days of the treatment. So in that cases the dose was comparatively going high. Nowadays one more thing is done is reduce the dose and make it per day dose. So suppose earlier dose was maybe 80 milligram, so give it 60 or 40 milligram per day. So that is how we can reduce the doses, or INS dose we can reduce, rifampicin dose reduce from 400 to even lower dose. So this is how we can reduce it dose and give it per day treatment. Eliminate the other, so either we can suspend therapy if it is very severe one, or we can manage the dose. Eliminate the other potential causes of hepatitis if simultaneously something going on like that. Consider the suspending most likely agent, which is permanently we can suspend it. Reintroduce the remaining drug once at a time with the most hepatic dose agents, first while monitoring liver function. Renal toxicity, suspend against suspected agent. Consider using capreomycin as aminoglycoside if an aminoglycoside has been problem in renal toxicity. Consider the dosing 2 to 3 times a week if regimen is available. Renal dosing is based on the creatinine clearance is done. ADR, other ADRs which can be there, like optic neuritis, which is because of ethambutol, stop it. Refer patient to ophthalmologist, usually reverses with the cessation of ethambutol. Electrolyte disturbances will be there, like hypomagnesium, hypokalemia, check it. Check potassium level, if potassium is low, or magnesium level, check it, and if it is problem, then continue. नहीं बराबर नहीं, अपने जीजे 13 है गाड़ी का नंबर, अच्छे इसमें लिख के लेना पड़ेगा अपने को. हाँ, नेम प्लेट लिखा के फिर उसके फोटो लेंगे अपन सब. मेरे को आना पड़ेगा उस दिन, अपन जाएंगे. करने कब करने वाला है वो? कल उसको बोलेंगे निकाल करके रख बोलना, और स्टैम्प करके अपन इस पे करके लेंगे. एक क्या नाम है उसका, मेरे पास कार्ड दे दे. हाँ, कार्ड लिख के, ठीक है, कर लेंगे अपन, कल लेके जाते हैं. Then take nursing care, that because we know it is a contagious disease, so keep the people away, guide them that don't have pregnancy during that drug interaction, check about it. Compliance is important. Good food is very important, because nutrient is very very important in that people. Go for open air or good sunlight. There are many things are there which has to be there, so go for this and make it. There are many new drugs are there. uh, I told you about bedaquiline is added into our latest guideline. It is not been there in many books. So there are many drugs are there. Why do we need new drugs in that? Because it should shorter the overall treatment duration. It should lower the relapse rate, because now at present relapse rate is very good, very high comparatively. Development of regimen which are having fewer adverse effects and less hepatotoxicity, because two important drugs or two main drug we can say they are hepatotoxic, so that is biggest problem. Development of regimen that can be given easily and safely in combination with antiretroviral therapy, because particularly along with that HIV is one of the complications that particularly in most of the cases nowadays are there which are having simultaneously HIV, and therefore that becomes again a complication. Development of regimens that are effective in treatment of uh, multi-drug resistance and extensive drug resistance tuberculosis, in that they can be useful, because newer drug will not have any kind of cross resistance. So these are various agents which are there. Hello. Ha हा येतो येतो. बरं बरं, एक 5 मिनिटात येतो मी क्लास हे करून. हां 5 ते 7 मिनिटात कुठं. बरं बरं, आलोच मी 5-7 मिनिटात. So there are various new drugs which are in practice. That is, drug name is delaminad. It is in phase 3. Then pretomaniad is in phase 3. Then sutezolid is in phase 2A. These are other are coded name at present. Names are not given, and these are from various companies. These drugs are there, and most probably this drug will slowly be tested, and accordingly they can come into practice. As I told you, more drugs in clinical development than any time, because in last 4 drugs no big changes has been happened into treatment. Only bedaquiline has been recently approved. As I told you, bedaquiline is there in our government of India's tuberculosis program also. It is first new TB drug after rifampin. You can imagine it, almost 40 years has gone. Delaminad is used for MDR treatment currently, which is approved in Europe. Multiple challenges we know that they are for the tuberculosis drug development. That is, we need combination of novel agents, clinical trial capacities, length of trials, because it takes years. Nobody is ready to go for that. Minimum treatment, if it goes for 6 months to 9 months, so how people will come for clinical trials, or how the clinical trial can be there? It is very extensive, and so many things are there, so it is depending. So these are various situations. Accordingly, treatment is a problem. Now, as I told you, homework is there. You can go for this and check this. I'll just show you about. So this is what the guidelines which shows. I am just going through the guidelines. So this is how this treatment is showing. So this is say 2 HRZD, that means these are for 2 months. Then accordingly you add here, it is month. Okay. So how the treatment is given, that has got a specific way of mentioning it. That is 2 means number of months, 4 HRE means isoniazid, rifampicin, ethambutol. These are very common. You can see it anytime. Here 18, it means 8 month. Now you can see that all are now daily doses, so it has not mentioned. But in previous cases, if you will go for, then you will find that it is per week the treatment was given. Okay, these are all treatment guidelines. You can see then bedaquiline has been added into treatment that you can go for. You can check about this. This is a bedaquiline. It is a new class of drug, that is diaryl quinoline, that specifically targets the mycobacterial ATP synthase. It is an enzyme which is essential for the supply of energy to Mycobacterium tuberculosis and most other mycobacteria. It is having strong bactericidal and sterilizing activity against Mycobacterium tuberculosis. It has shown in various preclinical laboratory and animal experiments. It has got a high volume of distribution. If the volume of distribution is high, that means it is present in all the body fluids, and therefore you have to increase the dose, or you have to add the loading dose for that. For extensive tissue distribution, highly bound to plasma protein and hepatically metabolized, the drug has been extended half-life, which means that it is still present in the plasma up to 5.5 months after stopping this bedaquiline. The dosing schedule has been established after extensive pharmacokinetic pharmacodynamic studies in animals and humans, and hence it needs to be administered as per the manufacturer's advice. Bedaquiline demonstrate no cross resistance with first and second line anti-tuberculosis. That is a very big thing. So this is additional drug which is available, and it has been recommended after June 13 that it should be used in this RN TCP guidelines, that is revised National Tuberculosis Program guideline, which has been introduced. To which patient it can be given? The patient received bedaquiline which are approved by Apex committee, that is adult age more than 18 years age, having pulmonary multi-drug resistance. Only in that we are using bedaquiline at present. Okay, so these are what various related to bedaquiline and other drugs. So go through these are various. Now these are very important thing is this is pediatric patients, how you are going. Each tablet is having weight prefix. This is a big difference. Actually, I asked this question some time back. How there are? What is the difference between previous guideline, that is NTCP and RNTCP guideline? So here it is giving even body weight wise number of tablet is fixed, but number of tablet will be changing accordingly. Okay. So see, this is very beautiful way of giving tablets. So go through this and referred book also simultaneously, particularly those who are referring Triparty and all, where the old regimens are given. In that you will find that it is 2 and then weekly will be given. That is, first is suppose 3 IR, that is INH and rifampicin, and then you will find that 3 at the end, just like we write X2, Y2 like that. Okay, so 2 will be there. That means thrice a week, 3 times a week. So now it is not been found. So number of days in a week is not given nowadays. That means it is a daily treatment. So go through this and please write this in your. Please take this as an appointment and add it. And I am expecting, because I will ask question not only from mode of action but from these guidelines also. These guidelines should help you to have a better idea during your pharmacotherapeutics. I think this much best idea will not be there. And if anybody asks you about guideline, this is the final version of a guideline which is government office giving. So take care and be safe. If you have any difficulties, you can ask me. But please put the. One more article is there. I'll just share it for a brief. So it shows various drugs which are in practice, which are going for this. These are lead optimization is means in the first stages, and those which are in the phase 3, these are various drugs in combinations. Different combinations are there. So where they are going, these are given. So you can I'll just explain you later. So how various drugs are there and they are being used, because after a long time again new leap is being taken for tuberculosis, and maybe we can find still better alternatives after some time. So, I take care, be safe, and if difficulties you can put there.